Thank you, Rick. I appreciate that. To my co-chairs, thanks for inviting us. The ACC is very happy to be part of this session, as always. I'd like to say that Cindy Grimes alone is responsible for many women going into interventional cardiology. You've been a role model for a lot of younger women, so bravo. The title of my talk is Heart Failure, Current Therapies and New Horizons, but Dr. Gepstein gave you all the new horizons. So I'm a little bit at a loss. I'm going to talk to you a little bit about some new medical therapies, but the new horizons clearly are stem cells. So we have many therapies for heart failure. They include medications, device therapy, heart transplants, and VADs. I'm only going to focus on a couple of newer therapies for medical therapy, but remembering that many device therapies, including VADs, are really a new horizon for us as well. This is a graph of the ACC-AHA stages of heart failure, and I want to just keep these in mind when we talk about therapies. I know you can't read all this, but what I'm going to focus on today is those patients who have symptomatic heart failure, who have stage C heart failure. Those are patients who have ever had symptoms of heart failure, and we know that those patients should be treated with ACE inhibitors and beta blockers. And if we go down the left side of the slide, those patients who have volume overload need diuretic therapy. We know that those patients who are self-identified African American patients will benefit from fixed dose hydralazine nitrates. And then on the left side, for those patients who do not have renal insufficiency, hyperkalemia, they would benefit from aldosterone antagonists. These are our current therapies for HFrEF, low ejection fraction heart failure. So what benefit do patients derive from these therapies? This is an important slide to show us the survival benefit that we see with, on the far left, ACE inhibitors and angiotensin receptor blockers. Beta blockers decrease mortality by about 40%. Mineralocorticoid receptor antagonists about 30%. What about the new drug on the block? We do know that one enzyme, neprilysin, degrades many endogenous vasoactive peptides that are listed here. Those are the natriuretic peptides, bradykinin, substance P, etc. With neprilysin inhibition, what we see is a decrease in neurohormonal activation, a decrease in vascular tone, decrease in cardiac fibrosis, and thus ventricular hypertrophy and atrial hypertrophy. We also see a decrease in sodium retention for patients. Remember that all progression in heart failure begins with some sort of myocardial injury or myocardial stress. With that myocardial stress or injury comes the maladaptive response that we call remodeling. We see increased activity to maladaptive mechanisms and decreased activity of adaptive mechanisms. And the concept of the newer heart failure drug that I'm going to talk about looks at the combination of an angiotensin receptor blocker and inhibition of neprilysin to halt this evolution and progression to heart failure. So the new medication is LCZ696, which is a combination angiotensin receptor and neprilysin inhibitor. You can see that it's a combination medication. And the Paradigm Heart Failure Study was the study that was a large randomized heart failure study combining these two therapies. Patients were given a dose of 400 milligrams daily of LCZ696 and enalapril, 20 milligrams daily. And importantly, the intent of this study was to specifically replace the current use of ACE inhibitors, which is standard of care, and angiotensin receptor blockers as the cornerstone of treatment of heart failure. This was not an equivalence study. This was a study to demonstrate superiority over ACE inhibitors. The Paradigm Heart Failure Study pre-specified endpoints are listed here. The primary endpoint was cardiovascular death or heart failure hospitalization, and then those two separate endpoints as well. Secondary endpoints were death from any cause. The KCCQ is a symptom evaluation, the Kansas City Cardiomyopathy Questionnaire. So that was a patient-reported outcome. Because of the fact that neprilysin inhibition was felt to be possibly related to additional onset of atrial fibrillation and decline in renal function. These two endpoints were followed as secondary endpoints. Can I have the next slide? See if we can do this. Frozen. There we go. What were the entry criteria? Patients needed to have symptomatic heart failure, class 2 to class 4. They had to have low ejection fraction. The initial ejection fraction of study entrance was less than 40%. This was changed to 35% in the middle of the trial to enrich the trial population. Patients had to have an elevated BNP or NT-proBNP. The NT-proBNP level could be lower if the patient had been hospitalized within the last 12 months. Patients could be on any ACE inhibitor or angiotensin receptor blocker prior to trial entry, but they had to tolerate a stable dose equivalent to enalapril 10 milligrams daily for at least 4 weeks. So this is an important part of this study. These patients had to tolerate enalapril going into the trial, into the run-in period. They also had to be on guideline-recommended beta blocker and mineralocorticoid receptor antagonists. Lastly, they had to have a systolic blood pressure at trial entry of 95 millimeters of mercury or greater. They could not have renal insufficiency or hyperkalemia. It's working. Okay, thank you. So this was the study design of the Paradigm Heart Failure Study. You can see that the run-in period involved first enalapril, 10 milligrams twice daily, then LCZ696, which was the neprilysin inhibitor. Patients were first given 100 milligrams twice daily and then 200 milligrams twice daily, and then they were randomized. Remember that patients only were randomized if they tolerated drug during the run-in period. Those patients who didn't tolerate drug were not randomized. Secondary endpoints we already discussed. Here's who was enrolled in the study. This was a very large study. Over 10,000 patients were studied in over 1,000 centers in 47 countries. A huge study. Very few patients were actually not included because they didn't fulfill entry criteria. So about 8,000 plus patients were randomized. Half to LCZ696 and half to enalapril. They were followed for 27 months. Very few patients were lost to follow-up. This was a very well-done trial. These are the baseline characteristics of patients in the Paradigm Heart Failure Study. Mean age was 63 years. There were about 21% women, which is about average for studies of HFrEF, especially those containing ischemic cardiomyopathy patients. You can see the ejection fraction mean was 29%. Importantly, patients were on beta blockers, about 93, 92%. They were on, half were on mineralocorticoid antagonists. Very few patients had ICD or CRT therapy. And an important part of this slide I want to show you is that the mean systolic blood pressure of patients enrolled in this study was 122. Remember that the blood pressure could be as low as 95. The patients enrolled in the study had fairly robust blood pressure. And here is the Paradigm Heart Failure primary endpoint. Compared to enalapril, there was a 20% reduction in cardiovascular death or heart failure hospitalization, which was the primary endpoint. There was also a 20% reduction in cardiovascular death in patients on study drug compared to enalapril. What about hospitalizations for heart failure? This was reduced significantly as well. In the United States, this is a huge issue, especially with regard to readmission to the hospital, because there's significant penalties to hospitals for admissions and readmissions. I know that you can't see the pre-specified subgroups, but suffice it to say that every pre-specified subgroup in this trial demonstrated benefit of study drug versus enalapril. And this is all-cause mortality. There was an 18% reduction in all-cause mortality in patients on LCZ696 versus enalapril. Remember, we talked about concerns about new onset atrial fibrillation and renal insufficiency. In the trial, there was no additional AFib with LCZ696, nor was there a statistically significant decline in renal function, and patients did feel better, as was evidenced by the KCCQ. Now, there was some concern about hypotension, And although there was more hypotension with study drug, there was not additional withdrawal of study drug compared to enalapril. There was also concern about additional angioedema with this new drug. This was not seen, at least not statistically significantly. So the summary of the findings, LCZ696 was more effective than enalapril in reducing the risk of CVD death and heart failure hospitalization by 20%, incremental decrease in heart failure hospitalization of 21%. Patients' symptoms were improved, and so were physical limitations. LCZ696 was better tolerated in that patients didn't have cough, hyperkalemia, or renal insufficiency, and it was less likely to be discontinued due to adverse events. So remember back to what we talked about, the benefit of ACE inhibitor and angiotensin receptor blocker. We see a 20% incremental benefit of LCZ696 over those two standard therapies. So what does this mean for care of our heart failure patients with regard to this medication? LCZ696 has been available in the United States now for about 9 months. And we've begun using it and have some experience. I think it's very important to remember the single-blind run-in period of the trial. Remember that patients who didn't tolerate study drug were not randomized. In our experience, we're seeing a little bit more hypotension than was seen in the trial, and you may be seeing that as well. So we've had more withdrawal from therapy than I would have anticipated based on these study results. The mean blood pressure was very high. Consider that when thinking about which patients you're going to use this medication. Patients were not that ill. They had class 2 symptoms. And for those of us in the United States, very few patients had ICDs. And so it remains to be seen in a patient population with ICDs what mortality benefit we'll see. Cost will clearly play a role, and I'll talk about that at the very end. I'd like to, no pun intended, shift our attention to ivabradine now and talk about the SHIFT trial results, which looked at ivabradine in similar patient group, moderate to severe chronic heart failure, low ejection fraction, less than 35%. Patients had to be in sinus rhythm and have a heart rate of higher than 70 beats per minute at the time of study entry, and they too had to be on guideline-directed medical therapy. The inclusion criteria are here. Patients could have either ischemic or non-ischemic cardiomyopathy, low ejection fraction. They also had to have had a documented heart failure hospitalization within the last 12 months. So this is a very similar patient population to that which was enrolled in the Paradigm Heart Failure study. This is the study design of SHIFT. Patients were screened for up to a month prior to study enrollment, and then they were randomized between ivabradine 5 milligrams BID and a matching placebo. And then you can see that over time, study drug was up-titrated according to patient tolerance. The study endpoints, the primary composite endpoint was cardiovascular death and hospitalization for worsening heart failure. And then other endpoints you can see were all-cause mortality, cardiovascular mortality, etc. Because of the concern that patients would be enrolled on less than target dose beta blockers, there was a stipulation in this trial that at least 50% of patients enrolled in the study had to be on target dose beta blockers. Target dose of beta blockers being defined as 50 milligrams, 25 milligrams twice daily as carvedilol, or 150 milligrams daily of metoprolol succinate. Over 7,000 patients were screened in the study, 6,500 and some randomized. You can see they were equally randomized to placebo and ivabradine. Very few patients were excluded. And again, this was a very good trial. Only 3 patients in total were lost to follow-up. The median study duration was 23 months, and this is the primary composite endpoint. Again, compared to placebo, patients on ivabradine had an 18% decrease in the primary endpoint, which was CV death or hospitalization for worsening heart failure. And this is the overall hospitalization for heart failure, a 26% reduction for those patients on ivabradine. Death from heart failure was decreased as well by 26% in patients on ivabradine. So what can we conclude from the SHIFT trial in low ejection fraction heart failure patients? There was an 18% reduction in CV death or hospital admission, 20% reduction in death from heart failure, and a 26% reduction in heart failure admission for worsening heart failure. The benefits were demonstrated very early on. The curves separated early, and they were, although I didn't show this data, the endpoints were consistent in the predefined subgroups of the study, and they were all these results were demonstrated on top of guideline-directed medical therapy. So who will benefit from ivabradine when we think about our patient population? We can see that these were the patients that were enrolled in the study. So importantly, the patients have to be in sinus rhythm. This drug has not been studied in patients with atrial fibrillation in large numbers, at least not yet. So they had to have a heart rate higher than 70, and they had to have had a heart failure hospitalization. Before we talk about cost, I want to mention that with the ivabradine study, importantly, although many of the patients were on beta blockers, there were 50% of the patients were not yet at target dose beta blocker. So one of the criticisms of the study is the fact that some of the patients should have been up-titrated to max dose beta blocker prior to enrollment. I'd like to end with talking about shared decision-making when we talk about new heart failure therapies. Dr. Chazal mentioned this with regard to patients in the emergency department with chest pain. Especially with these newer therapies, we have to talk about not only the results of paradigm and shift with our patients, but we also have to talk about cost. In the United States, valsartan sacubitril, which is LCZ 696 and it's called Entresto, costs $12.50 a day without insurance coverage, whereas again in the United States, a month's supply of enalapril costs a patient out of pocket $4. Now, there is growing insurance coverage for this therapy in the United States. As of this past week, about 90% of private insurance carriers are contracting to tier this drug so that so it's affordable to patients. But one of the important issues, in addition to talking about the paradigm heart failure study with patients, we also have to go through some fairly detailed discussions and shared decision making with regard to cost. And I'll end there and ask if there are any questions.